know that all randomized trials comparing elective coronary revascularization versus medical therapy in stable patients were underpowered to draw conclusions on cardiac mortality. The ischemia trial, that was a large randomized trial, was a negative trial comparing revascularization versus medical therapy alone at a median follow-up of 3.2 years. However, at 5-year follow-up, there were fewer cumulative cardiovascular deaths. Based on this background, we conducted a large-scale meta-analysis of randomized trials of available evidence comparing elective coronary revascularization versus medical therapy alone in stable patients with documented coronary artery disease. The key findings of this meta-analysis are very relevant. We found a significant and robust reduction of cardiac mortality in favor of elective coronary revascularization versus medical therapy alone after pulling together these randomized trials at the longest available follow-up. Importantly, there was also a parallel reduction in spontaneous myocardial infarction in favor of revascularization and was also related to cardiac mortality. Remarkably, there was a linear association, a direct association between the reduction of cardiac mortality and the increased follow-up duration, so that the magnitude of the mortality reduction is a function of both revascularization and also the length of follow-up. We also observed that the most employed drug types like antithrombotic or beta blockers or statins or also ACE inhibitors did not impact the cardiac mortality findings. The heterogeneity of the meta-analysis was low, and the residual heterogeneity was explained entirely by the length of follow-up and not by drug therapies nor by study year. We also observed other findings that are related to the fact that there was an enhanced benefit in terms of cardiac mortality reduction when there was an increased percent of multivessel disease. And all-cause mortality did not differ at the first analysis between the two strategies. However, when we deleted the trial with a very high crossover rate, there was again a significant reduction of all-cause mortality in favor of revascularization. Stroke risk did not differ between the two strategies. Our results were confirmed in all sensitivity analyses conducted. This speaks to the robustness and to the fact that the findings are sound, and these findings should have implications for direct catheterizations of patients with coronary artery disease.